Good evening, everyone. This is Meldita. I'm back here at my YouTube channel, MELDITA'S Info Corner. And this is my Facebook, johnrigacho@yahoo.ca. Okay, we have here late anterior STEMI. When we speak of late anterior STEMI or anterior STEMI, we have an anterior STEMI or big heart attack affecting the anterior portion of the left ventricle. Okay, so late anterior STEMI. We have here a 60-year-old man. Okay, his diagnosis is late anterior STEMI with VTAC and BFib arrest. Okay, the chief complaint here is he passed out. Okay, in history present illness, he was driving home after playing ball game, and then he felt that his level of consciousness is decreasing. Then he passed out. Well, his car hit a pole in the neighborhood, and there was a witness, bystander, who saw this. He called 911 and then approached the driver, and he was not breathing. He had no pulse, so he did CPR right away. The ALS, or the advanced life support of 911, arrived. They hooked the patient to their cardiac monitor, and they found the patient to be in VTAC BFib arrest. They defibrillated the patient one time with 200 joules, and the patient converted to sinus rhythm with ST elevation in the anterior and the anterolateral leads. So return of spontaneous circulation. Okay, regain his pulse. Regain, he was talking. So he regained his pulse. He regained breathing. He started talking. So the ALS gave the patient loading dose of aspirin 320 milligrams and Plavix 300 milligrams or ticagrelor 180 milligrams if their protocol allows them. Okay, and the patient got these medications, and then en route to the cath lab. The only history of this patient is this cardiac risk factor. The only risk factor is a strong family history with MI. Mom and dad had MI in the past. Okay. So when the patient was converted to sinus rhythm with ST elevations, okay, I have no strip of this VTAC BFib arrest being defibrillated, but they did 12-lead ECG, and this is what they found out. We have a fresh ST elevation in lead 1 in AVL, okay, and we have also here a little late presentation of Q and ST elevation in B2, B3, and B4. Okay, so this is an anterior STEMI, because we have a reciprocal leads 2 and 3 AVF. So the reciprocal here is inferior ST depression, leads 2, 3, and F. Okay, so if you have an anterior STEMI, your reciprocal will be inferior ST depression. But if you have an STEMI in the inferior, your reciprocal will be ST depression on AVL, and sometimes you could go depression on V and the anterior leads. But in our case, we have an anterior STEMI here, okay, anterior STEMI, though it is late presentation. We have a reciprocal here of inferior ST depression, lead to, okay, 2, 3, and AVF. Okay, they did another ECG 12 leads, which I'm not convinced because it's poor quality and we have lots of artifacts here. So I suggest that they should be doing another one, but I still have to interpret no matter what. It looks like we are developing a right bundle block in here, okay, but there's still ST in here, ST elevations in here. This B4 has no relation, but this 1 into 3, it looks like the patient might be developing a right bundle block pattern in here, sinus with right bundle pattern. But if you see the ST elevations in lead 1 and in AVL, it looks like the ST is coming from the isometric line. But as I told you, this could be a right bundle block pattern here, right bundle block with sinus, okay. It could be possibly. And then as I'm saying, this is poor quality. there are a lot of artifacts in here. Okay. So anyway, the patient ended up in the cath lab, and the interventionalist cardiologist found out that there's a blockage in the mid-LAD, and he applied 2 stents, drug-eluting stents to the mid-LAD. Okay. And then he did also a drug-eluting balloon on the distal branches, which are small but full of clots. We have here the septal and the diagonal branches. But what the doctor will do first is extract the clots extract the clots, and then apply the balloon inside. Okay, it's a drug-eluting balloon. Okay, why are they using drug-eluting stent for years now? Okay, before they used bare metal stents, but not anymore. So the drug-eluting stent has actually an anti-proliferative chemicals coating. Okay, there are coatings on the lining of the stents, and that's to prevent restenosis caused by intimal hyperplasia. What happens if these vessels are being manipulated, catheter insertion, dilation, stent application, we can actually create a vessel injury. So the response of the body is to produce more cells to fix the injury. And that's called the intimal hyperplasia. But we don't want the thing to happen, so we use drug-eluting stents to prevent this from happening because we don't want restenosis. Okay? So that is an anti-proliferative chemical. An example of that chemical is sirolimus. But there are others, but that's still the same thing. They are all anti-proliferative chemicals. Okay, in the case of this POBA here, so they do extract the clots. They do extract the clots from the smaller vessels. The doctor cannot put stents here because they are small. They can extract the clots, and he decided to do POBA. POBA is plain old balloon angioplasty, not using stent. So in this case, the balloon is coated externally with drug-eluting chemical. Okay, again, manipulation of these smaller vessels, entry of the catheters and ballooning everything, that can create a minor injury to the vessel, and the body will respond, or the vessel will respond by producing more cells to fix the injury. We don't want that thing to happen. So by using a drug-eluting POBA, as we inflate the balloon and then take out the balloon out, okay, these chemicals will stay in its place and prevent, intimal hyperplasia. With regards to the quality of how long it will be good, it's probably short-lived. But the stents nowadays, the drug-eluting stents, some say it could be, these drug-eluting stents, the effect of this anti-proliferative chemical, they are good, like for instance, 1 month, and some say it's as good as, that could be good until 3 months. Okay, the ejection fraction is 25 to 30%. It's low because the normal is 60 to 80 or 55 to 75. They say 50 is acceptable. The end diastolic pressure is normal, so the patient is not in failure. It's 7. It's a little bit on the low side, but that's still normal. And the patient is okay, not in failure. Okay, so anyway, the procedure was finished. We have here an anterior Stemi. We have a blocked LAD. So we did the stent insertion to the LAD. We POBA the septal and the diagonal. Okay, and as I mentioned, we have here an anterior Stemi because we have a reciprocal of inferior ST depression. Okay, so the procedure was finished. The patient was brought to CCU. After 1 hour, we did an ECG, and we came up with this. So we sustained here Q waves in V1, V2, and V3. So this is now the center of the effect of the stent insertion and the POBA. So it's mainly anteroseptal here. Okay, anteroseptal. Okay, we see that these Q waves are long. Okay, so we have an infarction, and then we have an inverted T wave starting, and we have also ST and T waves going down, and then we have also an ST going down and T wave starting to invert. And probably after 3 hours, the STEMI will be fully evolved, or the last phase of the evolution is finished. The STEM evolution is finished. Okay, so that's it. Now, after 4 hours, the patient developed some reperfusion.